Hello everyone. I am Docsaab and today I will be discussing riboflavin or vitamin B2, a small but important micronutrient with wide-reaching roles in cellular metabolism, antioxidant defense, hematologic health, and clinical medicine. Although it is often grouped among the routine B vitamins, riboflavin has implications that extend well beyond basic nutrition and into neurology, cardiovascular genetics, and mitochondrial disease. To begin, vitamin B2, commonly known as riboflavin, is a vital water-soluble micronutrient essential for human health and metabolic efficiency. Riboflavin is a yellow-orange crystalline compound characterized by its distinct isoalexine ring structure. Chemically, it is defined as 7,8-dimethyl-10-D1' isoalexine consisting of a heterocyclic flavin nucleus attached to a ribitol side chain. Its molecular formula is C17H20N4O6. Historically, it has also been known as lactoflavin, vitamin G, and hepatoflavin, reflecting both its discovery and its occurrence in biological tissues. An important practical feature of riboflavin is its light sensitivity. Exposure to ultraviolet or visible light rapidly degrades it into lumiflavin, which is one reason milk is commonly stored in opaque containers to preserve nutritional quality. At the biochemical level, riboflavin becomes clinically important because it serves as the precursor for two essential coenzymes, FMN or flavin mononucleotide or FAD or flavin adenine dinucleotide. The first is a flavin mononucleotide or FMN. It is formed by phosphorylation of riboflavin by riboflavin kinase, abbreviated RFK. It serves as a cofactor for approximately 30 human enzymes. It is also key component of complex 1 NADH dehydrogenase in the mitochondrial electron transport chain. The second is flavin adenine dinucleotide or FAD. It is synthesized from FMN by FAD synthetase. It functions as cofactor for approximately 80 human enzymes. It is critical for complex 2 succinate dehydrogenase in the electron transport chain. It is also essential for fatty acid beta oxidation and the citric acid cycle. Now let's see about history of the riboflavin. The first observation of pigment in milk with yellow-green fluorescence can be traced to English chemist Alexander Winter Blyth in 1872, though he did not identify it as a vitamin. Then research shifted toward identifying accessory food factors in milk, whole wheat, yeast, and liver, categorized as the vitamin B2 complex. Because no classical nutritional disease was directly linked to riboflavin deficiency, researchers utilized growth stimulating properties of food extracts in young rats to isolate the vitamin. And all this research leads to critical work by Richard Kuhn, Paul Georgi, and Theodor Wagner Jurek in Germany and Austria to the isolation and characterization of riboflavin as the second vitamin to be isolated and the first from the vitamin B2 complex. Then essential nature of the vitamin as a food constitute for human was established by 1939. Now moving to the biochemical roles and metabolic functions of riboflavin. In energy metabolism, FAD and FMN are critical components of the mitochondrial electron transport chain. FAD serves as the electron acceptor for succinate dehydrogenase complex 2 and is part of the iron sulfur clusters in multiple complexes. FADH2 produced during fatty acid oxidation and the citric acid cycle donates electron to the electron transport chain generating ATP. Beyond energy metabolism, flavocoenzymes also participate in the metabolism of carbohydrates, lipids, and proteins. They are involved in major reactions such as the pyruvate dehydrogenase complex, alpha ketoglutarate dehydrogenase, fatty acyl CoA dehydrogenase, and various amino acid oxidases and dehydrogenases. So, clinically, riboflavin deficiency can affect multiple metabolic pathways at once. Riboflavin also contributes to significantly to antioxidant defense. A key example is glutathione reductase or FAD-dependent enzymes that regenerates reduced glutathione and helps preserve cellular redox balance. Another FAD-dependent enzyme, xanthine oxidase, contributes to uric acid production, which also has antioxidant activity in blood. Its role extends into 1-carbon metabolism as well. FAD is required for MTHFR activity, specifically in the conversion of 5,10-methylene tetrahydrofolate to 5-methyl tetrahydrofolate, which is critical for folate metabolism and homocysteine remethylation. This helps explain why riboflavin supplementation can lower blood pressure in individuals with the MTHFR 677TT genotype. In iron metabolism, riboflavin is essential for iron absorption and mobilization from stores. Research in animals suggests that riboflavin deficiency may impair iron absorption, increase intestinal loss of iron, or impair iron mobilization from stores. Suboptimal riboflavin status is associated with lower hemoglobin levels and increased anemia risk. In the synthesis of other vitamins, riboflavin as FAD and FMN is required for the synthesis of niacin from tryptophan and in the metabolism of vitamin B6. Next, let us look at the absorption, metabolism, distribution, and excretion of riboflavin. Riboflavin absorption occurs primarily in the proximal small intestine. At physiological concentration, absorption is carrier-mediated via RFPTs, saturable, and sodium independent. At pharmacological doses, passive diffusion predominates. There are three specific transporters mediate riboflavin homeostasis. RFBT1 expressed in placenta and small intestine, RFBT2 ubiquitously distributed, highly expressed in brain, RFBT3 predominantly expressed in testes, small intestine, kidney, and placenta. These RFBTs employ an alternating access rocker switch mechanism, transitioning between outward facing, capturing riboflavin, and inward facing, releasing riboflavin conformations. RFBT3 is unique in being proton coupled and pH dependent, functioning optimally at pH 5.5. Once inside cells, riboflavin is phosphorylated by riboflavin kinase to form FMN, then converted to FAD by FAD synthase. Both cofactors bind tightly to apoenzymes but can be released and degraded when not needed. Then riboflavin is distributed to all tissues with highest concentration in the liver, heart, and kidneys. The brain maintains high levels via RFBT2 mediated transport. Total body stores are modest, approximately 20 to 50 mg, sufficient for only 2 to 4 weeks without dietary intake. Excess riboflavin is excreted primarily in urine, giving it a characteristic bright yellow color at high doses. Urinary excretion increase with intake. Levels below 40 micrograms per day indicate deficiency. From a nutritional perspective, daily riboflavin requirement vary by age, sex, and physiological state. In adults aged 19 to 50 years, the recommended intake is 1.3 mg per day for males and 1.1 mg per day for females. Requirement increase modestly in pregnancy to 1.4 mg daily and in lactation to 1.6 mg daily. For older adults, the recommendation remains the same. In infants, adequate intake ranges from 0.3 to 0.4 mg per day, while requirements gradually increase through childhood and adolescence, reaching 1.3 mg daily for adolescent males and 1 mg daily for adolescent females. These values are important clinically because deficiency may occur even when overt malnutrition is not obvious, especially in patients with increased physiological demand or reduced intake quality. In routine practice, riboflavin deficiency is often best prevented through diet. So important food sources of riboflavin include beef skirt stick 6 ounces 1.5 mg per serving, fortified tofu 1 cup 1 mg per serving, low fat milk 6 ounce glass 0.9 mg per serving, salmon 6 ounce fillet 0.8 mg per serving, mushrooms cook 1 cup 0.5 mg per serving, lean pork chops 6 ounces 0.5 mg per serving, spinach cook 1 cup 0.4 mg per serving, almonds 1 ounce 0.3 mg per serving, avocado 1 whole 0.3 mg per serving, egg 1 large 0.3 mg per serving, and other notable sources include liver including beef and lamb, cheese, yogurt, chicken, asparagus, broccoli, whole grains, and fortified cereals. Dairy products are the primary dietary source in many Western countries. Now to the clinical manifestation of deficiency. Clinically, riboflavin deficiency is classically referred to as ariboflavinosis, and its early signs are often most apparent in oral cavity. The oral manifestation include cheiliosis, means fissuring and scaling of the lips, particularly at the angles. Angular stomatitis means painful cracks at the corners of the mouth or labial commissures with severity grading from mild erythema to deep fissures with crusting. Magenta glossitis means a characteristic purplish red tongue, often with papillary atrophy. There may also be oral mucosal lesions, including stomatitis and mucosal inflammation. These findings are especially relevant because they may be mistaken for isolated local pathology unless the nutritional context is recognized. The ocular symptoms include photophobia, which is extreme sensitivity to light, lacrimation, meaning excessive tearing, corneal vascularization, which is invasion of blood vessels into the cornea, cataracts, where long-term deficiency is associated with cataract formation, and blurred vision indicating general visual impairment. The dermatological features include seborrheic dermatitis with distribution in the nasolabial folds, philtrum, genitalia, and scrotum or vulva. Discriminative dermatitis with scaling and erythema, and hair loss presenting as diffuse alopecia. Systematically, riboflavin deficiency can contribute to normochromic normocytic anemia due to impaired iron absorption and utilization, peripheral neuropathy with sensory and motor deficit, particularly in severe deficiency, fatigue presenting as generalized weakness and malaise, neurocognitive features such as depression, confusion, and cognitive decline may occur in advanced deficiency states. There is also association between migraine, which is particularly interesting because migraine frequency can respond to high dose riboflavin supplementation. So, from a clinical standpoint, deficiency should be considered not only in mucocutaneous disease but also in unexplained fatigue, neurologic symptoms, and hematologic abnormalities. Now, let's talk about genetic disorders related to riboflavin. Riboflavin is also highly relevant in inherited disease. One important example is riboflavin transporter deficiency, also known as Brown-Violet-Van-Lery syndrome. The pathophysiology involves mutation in SLC52A2, which encodes RFVT2, or SLC52A3, which encodes RFVT3. These mutations impair riboflavin transport, particularly affecting the brain and cranial nerves. These clinical features include progressive bulbar and spinal motor neuropathy, sensorineural hearing loss, respiratory compromise, facial weakness and atrophy, and limb weakness. The prognosis is poor if untreated, with a median survival of approximately 7.5 years. Early treatment is critical because late treatment often yields no benefit. Another group of clinically important disorders include multiple acyl CoA dehydrogenase deficiency, or MADD, and ACAD9 deficiency. In MADD, defects in electron transfer flavoprotein, or ETF dehydrogenase, impair fatty acid oxidation. Some patients show riboflavin responsiveness, especially those with ACAD9 deficiency, and may respond to high dose riboflavin, usually 100 to 300 milligrams per day. ACAD9 deficiency itself is a deficiency in acyl CoA dehydrogenase 9, a flavoprotein involved in fatty acid oxidation and complex 1 assembly. Treatment with riboflavin supplementation, also in the range of 100 to 300 milligrams per day, improves complex 1 activity and clinical outcomes. This is an excellent example of how vitamin therapy can function as targeted metabolic treatment rather than simple supplementation. From a clinical screening standpoint, several groups are at increased risk for riboflavin deficiency. These include patients with alcoholism, where absorption is impaired and excretion is increased, individuals with lactose intolerance who may consume less dairy, and patients with anorexia nervosa. Additional risk factors include hypothyroidism, adrenal insufficiency, chronic exercise, pregnancy, lactation, malignancy, and other chronic diseases. Prolonged use of certain medications such as tricyclic antidepressants, oral contraceptives, chlorpromazine, and probenecid may also contribute. In practice, these are the patients in whom low threshold assessment is particularly appropriate. For a diagnostic assessment, one important method is the erythrocyte glutathione reductase activation coefficient, or EGRAC. The principle is that it measures the degree of stimulation of erythrocyte glutathione reductase by added FAD in vitro. Greater stimulation indicates greater deficiency. A key limitation is that results may be unreliable in individuals with J6PD deficiency. Interpretation is as follows: optimal less than 1.10, acceptable between 1.10 to 1.19, low between 1.20 to 1.39, deficient greater than 1.40, severely deficient greater than 1.80. Additional assessment methods include urinary riboflavin excretion. measured either in a 24-hour urine sample or a fasting spot sample with creatinine correction. Values above 120 micrograms per day are normal, 40 to 120 are low, below 40 indicate deficiency, and below 10 suggest severe deficiency. Direct biochemical markers can also be useful. Plasma riboflavin below 7 nanomoles per liter, erythrocyte FAD below 50 nanomoles per liter, and plasma FAD below 20 nanomoles per liter are all suggestive of deficiency. Other functional markers include acyl carnitines elevated in fatty acid oxidation defects, organic acid including elevated lactate and ethyl malonic acid, homocysteine elevated due to impaired MTHFR function, and CSF lactate elevated in neurological involvement. Management is generally straightforward, but dosing depends on age and severity. In adults, the dose is 5 to 30 milligrams per day orally in divided doses, for example, 10 milligrams twice daily. The duration is usually 3 to 6 weeks until resolution, followed by maintenance as needed. Administration with food is important because absorption increases substantially from around 15% in the fasting state to more than 50% with meals. In pediatric patients, for infants, the dose is 0.5 to 1 milligrams per day. For children, 2.5 to 10 milligrams per day. And for adolescents, 5 to 15 milligrams per day. Clinically, response is often fairly predictable. Stomatitis and ileosis improve within 1 to 2 weeks, glossitis in 2 to 4 weeks, dermatitis in 4 to 6 weeks, and anemia in 6 to 8 weeks. Beyond correcting deficiency, riboflavin also has established an emerging therapeutic roles. In migraine prophylaxis, high-dose riboflavin at 400 milligrams per day has demonstrated efficacy in reducing migraine frequency, duration, and severity in multiple randomized controlled trials. The proposed mechanisms include reduction of oxidative stress, anti-inflammatory effects, and mitochondrial protection. In hypertension, riboflavin supplementation at 1.6 milligrams per day significantly lowers blood pressure in hypertensive individuals with the MTHFR677TT genotype. This targeted approach offers a non-drug treatment option for this specific genetic subgroup. In riboflavin transporter deficiency, high-dose oral riboflavin at 10 to 80 milligrams per kilogram per day or around 400 to 2700 milligrams daily for adults is the standard treatment, although responses are variable. Regarding safety and drug interactions, from a safety perspective, riboflavin has an excellent profile. Notably, there is no established tolerable upper intake level because no toxicity has been demonstrated even with high intake. Oral doses up to 400 milligrams daily for at least 3 months have not produced significant adverse effects. The vitamin is generally well tolerated, and the most common effect of higher dosing is bright yellow urine, which is harmless and expected. Rare cases of anaphylaxis have been reported with intravenous administration, but this is uncommon. Drug interactions remain clinically relevant. Tricyclic antidepressants and chlorpromazine may inhibit conversion to active coenzyme forms. Oral contraceptives may increase requirements, and probenecid can reduce gastrointestinal absorption. Now to recent research and emerging applications. In neurological diseases, a 2025 review in Frontiers in Neurology highlights riboflavin's emerging role in Parkinson's disease, Alzheimer's disease, multiple sclerosis, and acute brain injury. Novel delivery systems, including liposomal formulations and nanoparticles, are being developed to improve blood-brain barrier penetration. In cancer metabolism, a Nature study revealed that riboflavin-derived FAD is essential for FSP1 or ferroptosis suppressor protein 1 stability. Targeting the riboflavin FSP1 axis can sensitize cancer cells to ferroptosis, offering a novel therapeutic strategy. In women's health, recent studies suggest riboflavin may influence bone metabolism via HIF-related pathways and shows inverse association with osteoporosis risk in US female adults. In kidney health, population evidence links riboflavin consumption to chronic kidney disease outcomes, suggesting protective effects. Ongoing clinical trials from 2024 to 2026 include studies on effects on gut microbiota composition, post-exercise muscle soreness reduction, blood pressure lowering in MTHFR677TT carriers, and combinatorial mitochondrial therapies. In summary, riboflavin is far more than a routine dietary vitamin. It is a critical cofactor in energy metabolism, antioxidant defense, hematologic function, and inherited metabolic disease with growing importance in migraine, hypertension, neurology, and mitochondrial medicine. Thank you very much for your attention, guys. I appreciate your time, and I will be happy to discuss any questions or comments. And please like, share, and subscribe to the Docsaab's Diary.